I'm going to be chatting to you a little bit about putting all the data that Dave's collecting into some sensible measurements, because what we measure can be really, really stupid. And if you want some evidence of that, you can just look at me. Okay, so my watch tells me I walk 10,000 steps every day. But despite what you may believe, and your eyes might be fooling you, I'm not an ultra athlete. Okay, and if I tried to run those 10,000 steps, I'd probably collapse and need that 1978 defibrillator Dave was talking about. Okay, my watch literally congratulated me on walking from my car to this room today, so I think expectations, it's AI works in reverse sometimes as well, I think. So the past decade or so, I've been working a lot with data. So I am a medical doctor, but thankfully for patients and the medical legal fraternity, I don't practice on patients anymore. And what I've been noticing more and more is that with all this data coming through, we really aren't utilizing it effectively, and we're still measuring the same old things, but we could be doing so much more. So just some declarations quickly. I don't have any conflicts of interest like Matt, and the opinions are my own, but of course are correct. Right, so why do we measure stuff? Well, for most people, I think it's because really we have to. So we need to do reports, or we need to show some KPIs or our performance appraisals at the end of the year. People are asking us how many times we did X or did Y. And sometimes we're trying to manage stuff. So as you will progress in your careers into leadership, you will be looking at numbers and maybe some other types of data and trying to put it all together and figuring out how I can improve the service we deliver. But again, mostly because we have to, not because we want to. But fortunately for you guys, there are people like me and people like Dave who get very excited about data, okay, and we measure stuff because it's fun, okay, and it's awesome, and it actually is, and you guys better get used to it because you're going to have to start doing it soon yourselves, okay. So data tells you a story, and what we measure impacts what we do. So Mark Twain allegedly, again, cannot vouch for the saying, to be honest, says facts are stubborn, but statistics are pliable. Okay, and I think we know that now. We see fake news every day, right? And government releases statistics on unemployment, for example, and they say it's 29%, and that's terrible. But we're not counting those people who stopped looking for work. Well, they're kind of still unemployed, so maybe we should be counting them. And then they release other statistics, and annual reports from companies that are listed on the JSE release all sorts of statistics, really molded around what they want you to believe about them. Okay, so we can tell a story using data, but gear it towards our audience. And I'm going to show you a couple of examples of that. So this is why metrics matter. What we measure really matters. Okay, so let's take an example. And these numbers are fictional and are from no particular location. Okay. Let's assume an ambulance service had a priority 1 response time in under 15 minutes, performance of 48%. So 48% of its priority 1 cases, it was getting to in under 15 minutes. You would probably think, oh, it's not doing that well, okay? I mean, really, there's a lot of people out there who are probably dying. But if I took the same data and told you that the average response time for that service was 15 minutes and 23 seconds, you'd probably think, well, that's not bad. They do, 1 million cases a year, and they're getting to the average of those cases in 15 minutes, and that's pretty good. So what if I told you that an average EC waiting time, maybe not in the private sector, okay, but generally in the public sector, was 3 hours and 43 minutes. So most average, the median, patients will be seen in 3 hours and 43 minutes. That's actually pretty good, right, for most of the ECs. What if I told you the same EC was only seeing 13% of their patients, their red patients, in under 15 minutes? Now, suddenly your thoughts about that EC might change a little bit. You might think, maybe they're not doing what they're supposed to be doing. And for the heroes out there, well, we all like to drive with red lights and sirens. If you came and reported to your colleagues that 27% of your out-of-hospital cardiac arrests were surviving, people would probably put you on a donkey and ride you through on palm leaves and think you're the next great thing, right? Pretty awesome. Over a quarter of your patients are surviving. They're dead. You got there, they're dead. You use some machinery, which may or may not transfer to your local EC electronically, and you get them back. Pretty cool. But what if I said that 7% of those patients survive to discharge? It's not looking as good anymore. Okay, suddenly, And what if I said that the 7%, okay, of those patients that survive to discharge, 3% survive neurologically intact? So suddenly, you've gone from a superhero to creating an economic burden for someone who lives in a township who has to give up work and take care of that person for the rest of their lives. Pretty somber, right? I mean, like, what the hell? But that's the problem. It's the same thing, but we measure it differently. And I can report the 27%, and everyone will think it's wonderful. But the reality is not so wonderful. Okay, those numbers actually aren't that fake, funnily enough. They're taken from a study in Libya. So this is another thing. Let's go back to the EMS. So we measure P1 performance, right? So what if I told you, even more important, was that about 50% of those calls that were triaged P1 in the call center ended up being P2s. Okay, and we had a talk earlier, where's Kevin, who said that a large part of their job, thanks very much, is actually cancelling ambulances because they get to a P1 call and that's not a P1. Okay. But that also means that 50% of the P2 calls are P1. And we don't measure the time it takes to get to a P2 call. All right, it's a bit of a problem. So effectively, what it also means is that we could divide a dartboard in two, blindfold ourselves, or maybe not, if you're as accurate as I am, and throw a dart and be about as accurate in defining a priority 1 or priority 2 patient. And what if I told you that the primary metric reported at national level by all the provincial EMS agencies is still P1 response time under 15 minutes? You might ask yourselves, what the heck is the point of that? So, clever economics guy, Mr. Stiglitz, said, what we measure defines what we do, okay? So, if we measure the wrong things, it kind of makes sense that we'll probably be doing the wrong stuff, right? So if you have, I don't know how many of you have children, looking by around the room, it's probably like 3 of us. So if you judge your child on something that incentivizes poor behavior, don't be surprised if they carry on having poor behavior. Okay, discussion I have with my wife regularly, but it's me doing it, not her, by the way. So let me tell you a story, okay, of good intentions. So in 2000, the NHS decided they were going to rejig A&E services, right? So waiting times were horrible, the service was crap, and they wanted the best for their patients. So they introduced a target that 98% of patients who presented to an A&E, Matt was probably there at the time, okay, as was I, would be seen in under 4 hours. Any patient, right? So you can be a person with a sore toe, or the person having an MI, and you must be seen and disposed of, not like chucked away, but like disposed of as in have a disposition, within 4 hours. Sounds pretty awesome, okay? And they said, after measuring this for a while, that there's no doubt that this is an important catalyst for important change. It's a tough journey, but through innovation and collaboration, we've seen this target come to fruition, and it will improve the delivery of patient care and experience. Okay, so improve the delivery of patient care and experience. So, what happened? Okay, well, unfortunately, emergency care is part of a system. Okay, it's a bit like a balloon. You blow it up with air, and if you poke it in one place, not too hard, it'll bulge out at another place. All right, if you poke it too hard, it'll burst. Okay, so when we measure things and we create stuff in a complex system, sometimes we create changes that we don't predict down the line, which I think is adequately illustrated by our friends on the seesaw here. Sure, playing slow-mo. Oops. Watch this oak in the red jacket, by the way, watch him. So, the guy next to him bails. Plat now. Boof. Whap. Fractured hip. Lacquer. Check this oak in the red top. It's like, it wasn't me, bro. Like, seriously, I had nothing to do with this whatsoever. Like, bolts in the opposite direction. People are seriously stupid. I mean, really. It's why we'll never go out of business. Okay. So, they didn't intend for that to happen, but somebody thought it was a good idea to move a little bit closer to the middle, and so did the next guy, and the next thing they all fell off. So what happened with our story in A&E? Well, they decreased A&E waiting times. It was awesome, right? So, what happened after that? Well, they increased the volumes, because now people say, well, I've got to wait 2 weeks to see a GP, or I can be seen in under 4 hours, so I'd rather go to the A&E. I know I'm not that sick, but it's fine. And what happened from there? Well, they had to create these pseudo wards, right? So you guys might have had them in your hospitals if you work there, or certainly ambulance services know them. Medical assessment units or hall wards, so because they're stopping a clock now, right? They increased access block because now they're shoving people into wards, because it's not my problem. But now we have more patients that need to go, but we can't get them in there. And ultimately they decreased the patient experience, even though that statement before said otherwise. And again, some people of us who worked in the NHS know exactly this. It has done nothing for improving care. And I think the person coming up now who has literally the most unfortunate surname ever, Mr. Eatok, published this graph, which shows you that the rate of admissions from A&E is pretty steady. Okay, where's my buzzer here? That's that light green line, until 220 minutes. And then suddenly it spikes. So what's happening is people are watching the clock and going, oh crap, we better get these patients out of here. And they just bump them in. Poof, poof. So I don't think anywhere in the history of quality care metrics has pushing someone to a ward without definitive care improved quality of care. And that's published, and that is evidence available. So the reality is that customers, or in our case patients, consumers, don't care how hard we try, they care what we deliver. Okay? So poor performance with a great excuse is still poor performance. Okay, that's the reality. So what do we do about this? Well, in 2013, some clever guys by the name of Porter and Lee came up with a strategy in Harvard Business Review of the strategy that will fix healthcare. So they spoke about value-based care, right? And there were 6 things that they said we should start measuring. So the first, they said we need to integrate, right, across the care continuum. So this is something we've been speaking about for a while, right? Why do we operate in silos? We should stop operating in silos. Let's integrate. Let's work together. Cool, but we don't do it yet. We need to measure outcomes for every patient and costs for every patient and every event that happens to make sure that we're offering efficient and optimal care. We need to move to bundle payments for care cycles. So this is perhaps less relevant here, but maybe very relevant with NHI coming up, by the way, in terms of paying for a disease entity as opposed to fee-for-service. So if you go to a private hospital now, the doctor will give you a bill, the hospital will give you a bill, the path lab will give you a bill, the physio will give you a bill, everyone will give you a bill, and you don't really know what you're paying for, and it's expensive. What they're saying is you present to EC with a heart attack, you pay an amount for the heart attack, everyone gets out of that pot. If you do badly, if the patient does badly, sorry, you guys should up your game. If you do really well, good for you, you can keep the cream on top. Awesome. Integrate this care delivery across separate facilities and then expand it across the country and then enable it with an ICT platform, okay? Because we can't do this stuff without measuring it, and if we're not measuring the stuff, how do we know how well we're doing? So there's the equation that these guys come up with, which has been subsequently expanded a little bit. So they said value equals quality over cost. Okay, and they expanded that a little bit, and this is important because they said quality is outcomes and patient experience. Okay, divided by direct and indirect costs. So indirect costs, the lady who now has to quit her job to take care of her disabled child, okay, is a cost of that care event. Okay? Not saying that you shouldn't treat people and try and resuscitate them on the road, but we need to be cognizant of what we're doing. And in a resource-constrained environment, which this country very much is, unfortunately, we need to start thinking about that stuff. So, what? So what patients want actually matters, okay? Not so much what we want, what patients want actually matters. How we deliver the care we deliver impacts on the patient experience, and integrating this stuff, and there's a chat later about integrated care, which is cool, is going to hopefully impact on quality, cost, and care overall. So after all of this boring chat on Pythons and data and metrics, why do we still measure crazy metrics? And can we create metrics that share performance and share accountability to actually make sure we operate in an integrated way? So can this pipe dream, these unicorns, can they exist? Yes. So let me give you an example in a private hospital group. They decided to try this. So they took hip and knee replacement surgeries, and they said, right, let's bundle this stuff together, right? So they created a global fee that included the hospital stay, the consumables, the medication, the price of the prosthesis, plus the orthopedics fees, bundled it all together. Then they tiered doctors, and I was like, what? How can you tell doctors if they're crappy doctors? Well, we have to start telling people if they're crappy, unfortunately. So tier A, tier B, tier 3 doctors, tier C doctors, and they made it very transparent. So you knew if you're a tier C. You could try and up your game a little bit. They measured cost, they measured quality of care, they measured complications, they measured time in theatre, a whole bunch of metrics, and then they carried on and they saw what was happening. So what happened in this crazy, whimsical world of hips and knees? Well, they decreased the cost to the medical schemes, but at the same time, they decreased the time in theatre, they decreased the complications, they increased the fee to the doctor. Don't know why it's the doctors the whole time, but anyway, by over 35% within 3 years, right? They're already getting a big fee, now they're getting 35% more after 3 years as well. Maintain profitability for the hospital and increase patient experience. And to give you an example, in one instance, 100% of patients going for hip replacements receive blood transfusions. That is less than 5% now for the same doctor and the same type of patients. Now, it's not rocket science in terms of cost and quality of outcomes, what happens if you stop giving blood transfusions, especially when you don't need to, right? You can save it for the trauma patients. So, what I'm proposing is we start simple, okay? If we want to integrate care in this emergency care continuum, let's start simple, because on a high level, if you want to talk about calls, going through to the AMBO, going through to the EC, and going through to the ward, there's a lot of stuff we can measure. I mean, Dave spoke about it earlier. There's a lot of data. We could measure clinical quality, patient experience, direct costs and indirect costs for every single one of those silos, but I'm not sure it would actually improve anything. So I'm going to suggest 4 metrics we could look at measuring. What if we were all measured, EC, hospital, pre-hospital staff, on the correlation between call center triage and EC triage? And you guys are going to say, oh, come on, how can the EC doctor be responsible for how the person was triaged in the call center? But that's the point, right? That's the point. If we're not responsible for anything anyone else does in the continuum of care, then nothing's going to change and nothing's going to improve. So you could educate the pre-hospital practitioners. You could organize training. The pre-hospital practitioners who take the calls could understand better what patients look like and be forced to go on the road to see and understand what is a P1 and what is a P2, etc. Time of call to the ward, okay, like total time. Because I can get to a patient really quickly and drop them off at an EC and they can wait there for 8 hours. What's the point of that? Or take ages to get that P2, who's actually a P1, to the EC, and then the patient basically could die after crossing the red line. Again, how is the person working in the AMBO going to impact people working, or the time spent in the EC? Well, what about if we made sure who we picked up went to the right destination? What about if we didn't take people to facilities that didn't need to go to facilities? What about if when a facility called because they needed to transfer a patient out, we got there quicker so we could free up space and bed space and flat surfaces to get patients in quicker? Patient experience indexed per event. So imagine how grumpy people could be when the pre-hospital practitioner who refuses to get out of the ambulance for the patient and makes them get in the back themselves impacts on your score in the hospital. Likewise, imagine the little tussle that's going to happen when they've been very nice to the patient all throughout the journey, and they do that typical EMS palsy that happens in an EC, especially in the public sector, where everyone pretends that they can't see the ambulance who just came in, right? And that person will walk in there, and people like kind of do this little shuffle until like literally the person has to slap you on the back. They're like, oh, what a surprise, I didn't see you there, you know? So I mean, all of that stuff impacts the care we deliver, right, and the patient experience. And what if we looked at cost per clinical event? So instead of sending helicopters, David Stanton, for patients that didn't need them, we could take them by road to an appropriate facility. Or instead of ordering unnecessary blood tests in the EC, or blood cultures because the physicians want a blood culture on someone who's got pneumonia, we just didn't do that because actually it doesn't impact the care we give. So I think I'm going to wrap up now. But essentially what I'm trying to say is there's two questions you need to ask yourself. And these are the only two questions I think you need to ask yourself when you're developing a measure for how we use the data that we've got. So does improving on this metric improve value to the patient? So in other words, 15-minute P1 response time. If I go from 55% to 85%, does it matter to the patient? Well, no, because half of them are P2s, and half of the P2s are P1s, and nowhere in the evidence is 15 minutes noted anywhere that it makes a difference to outcome. So if someone has no airway and you get there in 15 minutes, it's too late, okay? If someone doesn't need resuscitation or ALS, if you get there in 20 minutes or 21 minutes or 19 minutes, does it make a big difference? I don't know the answer to that question. So does improving on this metric improve value to the patient? Second one is, does this metric share accountability across the patient journey? So let's start measuring stuff across the patient journey to the benefit of the patient and share responsibility and accountability and come up with some new metrics that actually count and actually make a difference in what we do. And then maybe, just maybe, we can start to actually share in the outcomes of the patients as well and ultimately improve the care we can give to them. Thanks.